Welcome to Applying Guidelines and Latest Evidence to the Management of Moderate to Severe Asthma in Children and Adults, presented by the Partners for Advancing Clinical Education in collaboration with the Asthma and Allergy Foundation of America, broadcast simultaneously on Immunology Live and ReInsight Live. My name is Dr. Anju Peters. I'm professor of medicine at the Northwestern University Feinberg School of Medicine. Today's session is interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Teresa Gilbert, who is the professor of pediatrics at University of Cincinnati. Welcome. And Stacy Denham, who's the public health manager at the Asthma and Allergy Foundation of America. Thank you, Teresa, and thank you, Stacy, for joining me today. Let's get started. Here are my and Teresa's and Stacy's disclosures. Our learning objectives for today include summarize the negative effects of comorbidities on the disease burden of moderate to severe asthma and on clinicians' ability to achieve disease control. Second is to explain the negative consequences of failure to achieve control of moderate to severe asthma on lung development in children. And finally, to apply current evidence and guidelines to identify appropriate biologic therapies for severe asthma based on phenotype, biomarkers, and comorbidities. Let's start with the first case, who is Monica. And this is a real case. This is a patient who saw me in clinic recently. Monica is a 42-year-old woman with asthma who reports 3 exacerbations in the past year requiring oral corticosteroids. She reports worsening nasal congestion and anosmia over the past 6 months. Her asthma is often triggered by worsening sinonasal symptoms, so she complains of upper airway symptoms, and then that worsens her asthma. She has poor quality of life. She can't taste food. She can't breathe well. She has difficulty concentrating, and she is truly scared of additional asthma exacerbations because then she goes on oral steroids. Her history is significant for sinus surgery 4 years ago. Her medications when she saw me were medium dose ICS-LABA and a nasal steroid spray that she takes once a day. On physical exam, most notable, she had wheezing on forced expiration, and her labs, her IgE was 150 IU per ml, and her blood eosinophils were 500. Here was Monica's spirometry when I first saw her. You can see the forced volume. You could see her FVC was 2.55, 70%. Her FEV1 significantly reduced at 1.49, and a ratio of FEV1 to FVC was reduced to at 58%. You could see her expiratory flow volume loop shows the curve that we typically see the scooping consistent with asthma. So this is the first question. Which of the following best describes Monica's asthma? A, mild, B, moderate, C, intermittent, and D, difficult to treat. So while you answer, I would like to bring Teresa into the discussion a little bit. So Teresa, is this how you would think of asthmatics when they show up in peds clinic? You know, I do mostly adults and you do mostly peds. Would you think of it this way? So I think, Teresa, you might be on mute.
Sorry. Thanks.
There you go.
Yeah. So the first thing I think about with nasal polyps is, does this child have cystic fibrosis? But I do have a handful of adolescents with severe asthma that also can have nasal polyps.
Got it. So I think you kind of jumped forward a little bit, but that's okay. Our question was on the different ways to describe someone's asthma based on severity, but that's okay. I mean, we are going to go on to comorbidities.
We do use the term difficult to treat asthma for sure.
Yeah. And the result, the poll answers have come back, and the most common answer was D, difficult to treat, which is the correct answer. And we'll keep moving on. So this is a slide actually made from GINA guidelines. The GINA guidelines, you know, it's amazing. They have been an international guidelines for management of asthma, help patients, help healthcare workers. And this year is their 30th anniversary. They first got together, the World Health Organization and the NHLBI, in 1993. But let's talk about difficult to treat and severe asthma. So what proportion of adults with asthma have difficult to treat or severe asthma? And this was answered based on a study done most in Netherlands. So when we think of all asthmatics, about 24% of asthmatics are on high intensity treatment with high dose ICS LABA or medium dose ICS LABA and often oral steroids. Of all asthmatics, about 17% are difficult to treat asthma. And when we say difficult to treat asthma, we do not mean difficult asthma. These are asthmatics who need high intensity treatment. So high dose ICS LABA, medium dose ICS LABA, often with steroids, for either symptom control or continue to have poor symptom control. Of all asthmatics, severe asthmatics are a subset of this difficult to treat asthma. And we think the prevalence is between 3.7% to about 10%. And severe asthma has been defined both by GINA guidelines as well as by the ERS ATS task force. And a consensus was published in 2014. But basically, and I know Teresa will talk about it too, but basically severe asthma is defined as asthma that requires treatment with high dose ICS plus a second controller and or oral corticosteroids, or remains uncontrolled despite therapy. The easiest way I think of it is, in difficult to treat asthma, there are still factors that could be needed to be controlled, such as comorbidities, how someone's using their inhaler, adherence, while severe asthma takes into account all those factors. So all of the comorbidities have been addressed, potentially adherence has been addressed, correct inhaler techniques, etc. So here's a decision tree that helps in management of adult asthma based on GINA guidelines, going from difficult to treat asthma to severe asthma. So first of all, if an individual with asthma presents to us with moderate to high dose ICS and a second controller, is not well controlled, has a poor symptom control, has repeated exacerbations or more than 2 exacerbations, one of the most important things would be to confirm the diagnosis of asthma first. Interestingly, more than 1/3 of people in a study who were thought to have asthma actually had something else. And it's important to confirm the diagnosis so we don't give someone treatment if they don't need it, and also to improve their disease control. How do we confirm the diagnosis of asthma? Typical, based on everything in medicine, a good history, typical symptoms of asthma, typical history, cough, shortness of breath, wheezing, chest tightness. Often variability where it comes and goes. And we also need lung function for confirmation of diagnosis. During COVID, we didn't do it as much, but now we're back to doing it. And often things like pheno, family history also help us. Once the diagnosis is confirmed, then these individuals should be assessed for comorbidities that contribute to disease severity. We also assess for other factors. In asthma, this is so important. We assess for environmental factors, allergies, smoke exposure. Right now we have the Canadian wildfires really causing a lot of problems here. We assess for these factors. We optimize management by asthma education, comorbidity treatment, making sure medications are optimized. And then the severe asthma diagnosis is more of a retrospective diagnosis after 3 to 6 months of optimizing management, treating comorbidities, etc. So once the diagnosis of severe asthma is made, that's when we would start a treatment plan. So as we talk about comorbidities on Monica, on exam, you notice she has bilateral nasal polyps. What would you consider next? For this question, would you get A, a sinus X-ray, B, a sinus CT scan, C, you would increase her nasal steroid spray to twice a day from once a day, and D, increase her dose of ICS-LABA. So while you answer this, Teresa, as you mentioned, you sometimes think of nasal polyps. In children, you think of CF. In my adult clinic, chronic rhinosinusitis with and without polyps is actually seen quite often. How often would you say you would see it?
It's pretty rare. Like I said, older adolescents in my practice, I'll see nasal polyps, but I'm pretty quick to get a sweat chloride to make sure I'm not missing it, because about half of patients with cystic fibrosis also can have bronchodilator reversibility. So there is some overlap there. So I would be checking that just to be sure. But I do see a handful. So maybe 1-2%, something like that.
Yeah, and that's exactly, this is where there are some differences between adult and peds. And, the good thing is we'll go over both today. I will tell you, every severe asthmatic I see, we would think of chronic rhinosinusitis, in addition to some of the other comorbidities we'll talk about, as one of the most important contributing factors leading to disease severity. And, CF, we do see it every so often as well, that is missed in childhood. So the correct answer, as most, was answer B, which the audience also responded. And more we have realized it used to be people would check sinus x-rays. That just not is the best way to look at our sinuses. A CT scan is very low radiation. It's without contrast, gives you very good objective evidence of disease. The other C and D really wouldn't make much difference in terms of her nasal polyps. So moving on to the next slide. So while we talk about chronic rhinosinusitis, it's important to note there are many comorbidities that are associated with asthma. Some of these are important to treat because if they're not treated, then they lead to worse disease control, increased risk of exacerbations, while some may be associated with more severe asthma. And, many of these comorbidities include allergic rhinitis, sleep apnea, GERD. Any type of a psychiatric illness potentially could lead to worse asthma control and increased exacerbation, while others such as EOE are commonly seen in both adult and peds, but much more in peds, as Teresa would say. For today's talk, we'll focus on one of my passions, which is chronic rhinosinusitis, and let's move on to that. So chronic rhinosinusitis is actually quite common. 8 to 12% of the population suffers with it, both children and adult. When we think of chronic rhinosinusitis, it could be chronic rhinosinusitis with nasal polyps, typically abbreviated as CRS-WNP, or chronic rhinosinusitis without nasal polyps, which is abbreviated as CRS-SNP. On the bottom panel, you can see an endoscopy view. And the first is normal. You see the inferior turbinate on the left-hand side. Next, you see a sinus CT scan. You see the eyes that are the circles in the middle. And then you see the maxillary sinuses with the gray, which is mucosal inflammation. And the black is air, which you want really the sinuses to be more black. You see polyps on endoscopy view in the middle panel. And on the last panel, you see pus draining, which is chronic rhinosinusitis without polyps. Now, CRS, or chronic rhinosinusitis, by definition, is symptoms. Classic nasal symptoms include congestion, drainage, facial pressure, loss of smell, postnasal drainage, anterior drainage. And these individuals just don't feel well, and symptoms are present for 12 weeks or more. You diagnose it based on symptoms and evidence either by a CT scan or endoscopy. So as I mentioned, CRS is something I see a lot, and there are studies done both in Europe as well as in US looking at the prevalence of CRS in patients with severe asthma. This is a slide from UBioPred, which is a consortium of asthmatics in Europe, both industry as well as academic centers and patient groups. And you can see in severe asthmatics compared to healthy controls, nasal polyps are present in more than 1/3 of patients with severe asthma. Above it, you see something called SNOT-20, which is a quality of life measure. And the SNOT-20 is higher. The higher the score, the worse quality of life in these patients. And the more severe asthmatics have more nasal polyps and higher SNOT-20 scores. Here's a study that was done at Northwestern, and the first author was Marielle Benjamin, who was a resident and fellow with me and now is an attending at University of Michigan. And when we looked at the clinical characteristics of our chronic rhinosinusitis patients at Northwestern, so SNP is without nasal polyps and WNP is with nasal polyps, you could see that more than 1/3 of our patients with CRS without nasal polyps had asthma that was diagnosed by either a pulmonologist or an allergist. And more than 50% of with nasal polyps have asthma. So it goes very much hand in hand. So this moves us on to our next question, which is how would you rate your awareness of the impact comorbid CRS with nasal polyps may have on Monica's asthma? A, extremely aware. B, very aware. C, somewhat aware. D, not very aware. And E, not at all aware. So while you guys answer, so Teresa, as you mentioned, you see polyps every so often, not that often. How about chronic rhinosinusitis without polyps?
We definitely see that. And I don't know how much awareness there is about that, but definitely something that we see in children that have a lot of facial symptoms, a lot of headaches, a lot of drainage that keeps coming back, that's not well controlled with allergy medications. We definitely think about it.
Yeah, very true. And, we aren't really talking much about allergic rhinitis, but allergic rhinitis, I don't know if you picked it up on the UBioPred study slide. Allergic rhinitis, chronic rhinosinusitis goes hand in hand. In fact, almost 70% of patients with nasal polyps have allergic rhinitis. So, and almost 50% of CRS without nasal polyps have allergic rhinitis. So the answer is back. The most common answer came back at choice C, somewhat aware. So I'm glad we're talking about it to increase awareness. So let's move on more to increase awareness of CRS with nasal polyps and severe asthma. This is a slide actually from Severe Asthma Network in Italy. There's similar data done in US as well. And what they looked at was impact of CRS with nasal polyps in severe asthma patients. And as you can see, CRS with nasal polyps is the lighter blue, and the darker blue is individuals with severe asthma without nasal polyps. So exacerbation rate was higher in those with nasal polyps. They were more likely, if you look in the middle panel, to get oral corticosteroids a year, quite a bit of oral corticosteroids, as you can see. And compared to individuals without nasal polyps, those with nasal polyps often tend to have much higher prevalence of long-term oral corticosteroids. This, as we now use more biologics, obviously has gone down quite a bit. But this is something when I first started, we had so many patients dependent on systemic corticosteroids. Here's a study from Northwestern where we looked at sinus severity and asthma severity. On the y-axis is LMS, or Lund-Mackay score. This is a way of scoring sinus CT severity. The higher the score, the more severe disease. And as you can see in individuals with chronic rhinosinusitis without asthma, moving on to intermittent or mild asthma in the middle, and the last group is the moderate to severe asthma. These are the individuals that tend to have more severe disease. And the opposite is true also. Sinus CT severity, as I mentioned, is worse with more severe asthma, but asthma is more severe as your sinus severity gets worse. So nasal polyps, we tend to think of being the most severe. So interestingly, there's overlapping inflammation in asthma and CRS with nasal polyps. I'd like to present that next. It's very similar. We often say CRS with nasal polyp is like having asthma of the upper airways. So here's a slide that is from New England Journal from a few years ago from Elliott Israel, where they looked at inflammatory mechanisms of asthma, the endotype of asthma. And we think of asthma being type 2 high or type 2 low or non-type 2. Majority of severe asthma we think is type 2 high, although there can be a lot of mixed asthma too. Our airway epithelium is faced by allergens, bacteria, etc., releases alarmins such as TSLP, which then promotes type 2 inflammation. The classic type 2 cytokines are IL-4, 5, and 13, which promote what we call type 2 inflammation with eosinophilic inflammation, IgE production, etc. This was from asthma. This is a slide from Northwestern in terms of type 2 inflammation in nasal polyps, and very similar. The airway epithelium in the upper airways is faced by allergens, bacteria, viruses, pollutants, smoke, leads to release of alarmins, which we think of as type 2 inducers, TSLP, IL-25, IL-33. These then promote type 2 inflammation by activating Th2 cells, the IL-C2 cells, lead to the release of type 2 cytokines, IL-4, 5, and 13. IL-4 and IL-13 are important in IgE production, mucus secretion, airway remodeling, and then IL-5, the classic eosinophilic survival cytokine, increases eosinophilia, increases inflammation. And when we looked at this actually at Northwestern, we looked at our inflammatory endotypes. What are the mechanisms that lead to CRS with nasal polyps? Just like asthma, what is in red is type 2 inflammation. 87% of our CRS with nasal polyps was type 2. And we looked at this by looking at IL-13 expression, the classic type 2 cytokine, and you can see IL-13 is elevated in nasal polyps compared to control. ET stands for ethmoid tissue. And this is very similar to severe asthma, where we think about 80% is type 2. And then you can see that there are other endotypes, type 1 or type 3, which is neutrophilic or even mixed endotype. So moving on to asthma management, from when we think of mechanisms, we then think of how we would treat asthma. The GINA guidelines basically says for classic asthma management, we use personalized asthma care. We think of it in terms of assess, adjust, and review. And this is a continual cycle. You assess them for two most important domains for asthma control, symptom control, and potentially decreasing asthma risk of exacerbation. So we assess their comorbidities. We assess different factors we can modify, assess inhaler technique. Shared decision-making is really important. It improves patient satisfaction. We do a lot of education, and when you move from assessing to adjust, you again treat modifiable disease risk factors, comorbidities, and then you always at every visit review for how symptom control has been through different questionnaires that are available. We check lung function, check for comorbidities, again, keep moving on. Here is based on GINA guidelines, personalized treatment steps for adolescents and adults, and Teresa will talk in children. There are two different tracks. They're very similar. They're differentiated based on using the track one, which is preferred best evidence, uses as needed low dose ICS and formoterol for reliever therapy, the SMART therapy. And you move up steps depending on symptoms and disease severity. Let's talk about step 5. The highest step. These are patients who are not controlled on ICS formoterol and high-dose ICS LABA. They continue to have poor symptoms. They have exacerbations. What are the next things we can do? One, we can add on LAMA, so muscarinic agents, and there's some evidence for that. This is where you'd assess their phenotypes. Are they allergic? What type of inflammation do they have? You look at comorbidities. And then depending on what type of inflammation you think, currently we have very good biologics that target type 2 inflammation. We would do that for asthma. Similarly, in nasal polyps, basic treatment is saline rinses, topical nasal steroid sprays in the nose, just like we use inhalers in the lungs. Antibiotics, just like in asthma, we only use for infectious exacerbations. We occasionally will use leukotriene modifiers. For exacerbations of CRS, we'll use short courses of oral steroids, limited due to adverse effects. And then if medicines don't control symptoms, then surgery is the next option. In fact, that's what we had, and many people got repeated surgeries, but now we have the option of biologics. And on the right-hand side is a study that was done. This was a study from US, a multi-center study, really good surgeons. They followed their patients for about 10 years and found that 40% of individuals with CRS with NP, after they underwent surgery, would have recurrence of polyps. So really, there's quite a bit of unmet need, and this is where biologics come on. So we know biologics are useful for asthma and nasal polyps. And based on this is, again, a figure that we used in one of our papers in 2020. The airway lining, as we talked about, is faced by irritants, pollutants, etc. The alarmins lead to release of the type 2 cytokines. The different biologics that are approved for asthma are listed here. Tezepelumab targets TSLP. Dupilumab, which is IL-4 receptor antagonist, targets IL-4 and IL-13. Omalizumab targets IgE, and meplizumab and reslizumab target IL-5, the eosinophil growth factor, and benralizumab targets IL-5 receptor alpha on eosinophils. Here's a slide showing you all of these biologics. All of them are approved for asthma. The different targets are mentioned here. They're approved for children as low as greater than 6. And, Teresa will talk about this more. Some are approved for over 12. What I'd like to talk about is that 3 of these are actually approved for CRS with nasal polyps, dupilumab, meplizumab, and omalizumab. They're approved for adults in nasal polyps. We see those type of polyps in adults, the type 2 types. You can see they are given by sub-Q. Reslizumab is IV, and the doses are noted here as well. So, there are multiple biologics both for asthma and nasal polyps. How do we decide this? This was very well presented in GINA, and this is such small fonts, but let me go over it with you. So when we first assess for severe asthma, you assess the phenotype. You then decide what kind of comorbidities you need to treat. You look at factors, you make sure there is adherence. And in individuals that have type 2 asthma, and there is ways to tell if they're type 2, if their FeNO is high, if their eosinophils are over 150, if they tend to be allergic. And if they still have poor control despite high-dose ICS/LABA, adding a LAMA based on insurance coverage, based on shared decision-making, you would then consider a biologic. Which biologic would you choose? The eligibility criteria depend on different countries, are mentioned in the middle column. So omalizumab, you would consider it in someone with severe to moderate to severe allergic asthma, especially, these are individuals who have IgE but over 30. They have to be sensitized either by skin test or by serology to a perennial allergen. Anti-IL-5 ones, so benra, reslizumab, or meplizumab for asthma, potentially, if they have blood eosinophils over 150, anti-IL-4 receptor antagonists or dupilumab would be eosinophils over 150, and typically FeNO over 25, or those that are on systemic corticosteroids chronically. And then anti-TSLP, which is our newest one, is also approved for asthma. We use it for type 2 and potentially also for non-type 2. All of these work well if someone's, you wouldn't use it unless someone's previously had asthma exacerbations needing systemic steroids. We also have predictors of who responds to these medications. And these are listed on this column. Typically, those with EOs greater than 250, 260, FeNO that's higher, and those that have had exacerbations. Similar to asthma, there are multiple biologics for nasal polyps. This is a table that lists for you different biologics, which outcomes improve with the biologics. For example, you could look at quality of life. You can also look at nasal polyp score. If it's all dark green, it's the best. And you can go through this at your own time, but it helps you choose biologic in clinical practice. So let's move on to Monica, who had worsening upper and lower symptoms despite surgery. She was started on a biologic and followed up in 3 months. She had improvement in her nasal symptoms, smell and congestion, and taste came back. She was able to exercise better, has not needed oral steroids, feels overall better. On exam, her polyps are smaller, her lungs are clear, and her lung function has actually improved. So with this, I'd like to end. In conclusion, type 2 asthma is associated with comorbidities. We focused on nasal polyps, but there are many more. CRS with nasal polyps is more severe in patients with severe asthma. Polyps can recur after surgery, especially in patients with asthma, and this is where type 2 biologics help. Type 2 directed biologics are approved for both asthma and nasal polyps. The ones that are approved for both include dupilumab, omalizumab, and meplizumab. There are others being studied as well. And with this, I'd like to move on to my presenter, Dr. Gilbert, who will start with the case presentation. Teresa.
Thank you. Taking myself off mute. And so, hello all. Thank you for coming today. And I'm excited to present on a topic I'm passionate about, which is severe asthma in children. So first, we're going to start out with Adrian. He's actually a patient that I, too, have seen in clinic. He's a 10-year-old Black male who's new to your practice, we'll say, who was diagnosed with asthma at 5 years of age. Mother reports that despite him being on high-dose inhaled corticosteroid and a long-acting beta agonist for his age, he continues to experience daily asthma symptoms. He frequently needs to use his albuterol, and he's had several severe asthma exacerbations requiring oral corticosteroids and a hospitalization in the past year. This has had an impact on, how much he can play, his school attendance, and he's not been able to join football, which he really wants to do. Because current labs are blood eosinophils of 250 cells per microliter, an exhaled nitric oxide of 25 parts per billion, and a total IgE of 15. So as Dr. Peters mentioned, there's a couple different definitions of severe asthma floating out there, but there's some common ground here. First of all, they both GINA and the ERS, which is the European Respiratory Society, and the American Thoracic Society, all agree that we start talking about severe asthma when they're 6 or above, as well as adults. And they have the common theme that you're on high doses of medicine and you either remain uncontrolled or once you step down, you lose control. And GINA kind of sticks to the high dose inhaled corticosteroid and a long acting beta agonist, whereas ERS and ATS sort of bring in, it could be a second controller, like it could be a long acting muscarinic agent or a LAMA, or it could be systemic oral corticosteroids. Either way, if you're uncontrolled on that high dose, or when you try and step them down, they lose control. So either are considered severe. And there's several steps to difficult to treat asthma. And Dr. Peters, again, sort of covered these. They're similar in adults with the GINA guidelines, but we really want to confirm the diagnosis. So we want to evaluate, first of all, treatment adherence. I mean, if you look at database studies of adherence to therapies, it's dismal. It's like 30 to 50% of prescribed meds are actually taken in real life. Inhaler technique, as Dr. Peters mentioned, is very key. I see patients all the time copying Hollywood and squirting things into their mouth when they're only 4 years of age, and they definitely need, more of a mask and spacer type technique. Pollution, smoke, environmental exposures at home is really key. Anxiety and depression is not atypical and can worsen asthma. They can have other comorbidities, allergic rhinitis. They can have obesity. They can have gastroesophageal reflux, many comorbidities that can worsen asthma. And then lung function really helps confirm the diagnosis. You want to see reversibility, or when you exercise them or give them methylcholine challenge, you actually see some obstruction that's reversible that helps confirm the diagnosis. And if the diagnosis is in question, well, sometimes we will actually do bronchoscopy to look at airway structure. We'll think about cytology either through a sputum culture or a bronchoalveolar lavage to kind of see what the airway inflammation is. And then there are also tests for corticosteroid responsiveness. Once you kind of go through all that and you still have somebody that's uncontrolled, so you confirm the diagnosis, they're still uncontrolled, that's when we sort of arrive that maybe they truly have severe therapy-resistant asthma. So now I'm going to turn it over to my co-presenter, Stacy, who's going to present some of the demographics and healthcare disparity that we see in severe asthma in children.
Thank you so much, Dr. Gilbert. So speaking to severe asthma and difficult to treat, we know that in the U.S., there are about 4.8 million children living with asthma. And most of these children with asthma have a mild form of the disease and are able to control their asthma with low to medium dose of inhaled corticosteroids. Yet about 5% of those children remain symptomatic despite going on high-dose ICS. Looking more closely into these statistics, we know that 50% of all healthcare costs associated with asthma come from moderate to severe asthmatic population. So that's a very large number burdening our economic healthcare system right there. So when you look at it even closer, asthma among children continues to remain a public health challenge. And among these children ages 5 to 17, asthma is one of the top causes of missed school days. So children with uncontrolled or poorly controlled asthma, as we have spoken about just a few slides ago, have higher risks of severe exacerbations, multiple missed school days, hospitalizations, and even permanent lung damage. And looking at those statistics even further, we know that asthma rates are highest in children who are Black, Puerto Rican, and Indigenous peoples within the U.S., those of low socioeconomic status, and those living in the inner cities and near high amounts of air pollution. So when you factor all of these things in and you put it in a nice infographic like this, I really love this infographic because it gives you a nice visual about the Black, Hispanic, and Indigenous individuals in the U.S. and how they face the highest burden of asthma and how we as public health professionals are called to dispel that disparity and really call to action to change that. So compared to white Americans, Black Americans are nearly 1.5 times more likely to have asthma, and Puerto Rican Americans are nearly 2 times more likely to have asthma. Black Americans are 5 times more likely to visit the ER, and they are 3 times more likely to die from asthma. So that mortality rate is really high. And then when you factor sex into that equation, we find that Black women have the highest rate of death due to asthma. So these disparities are continually striking. And this slide is a great depiction of asthma prevalence and mortality among children less than 18 years. So you can see it once again, Black Americans hold the highest asthma prevalence and mortality rate, followed by Indigenous peoples in the U.S. and Hispanic peoples. And again, these graphs give a great visual to the disparities of asthma among children and further emphasizes the importance of achieving proper asthma control across the board and ensuring equitable access to healthcare for all communities that we serve. And with that, I'll forward to the next slide and hand it over to Dr. Gilbert.
Well, that was very interesting, Stacy, and certainly something that I see play out in my own clinic. So Stacy mentioned that sometimes we can see permanent effects on lung function. And this is a slide that I think really highlights that. So this is from the CAMP study. It was a study of 684 children that were aged 5 to 12 at the start of the study. They had mild and moderate persistent asthma, so they didn't even have severe asthma at the start of the study. And the study was longitudinal, so it followed them over time until they were age 30. And what we can see is about 25% of these children that had mild to moderate asthma had normal lung function at age 30, but about 75% showed some patterns of abnormal lung function. So 26% had early decline, meaning they reached normal lung function in their 20s, but then are declining and having a loss of lung function more rapidly than other adults. Then the next group we see has 23% had reduced growth, meaning that they didn't reach normal levels during childhood, but are losing lung function at the same rate as other adults. And then we have the saddest group, which is those that never attained normal growth during childhood and then had an early decline in adulthood. And in fact, 11% of the patients in the reduced growth and early decline groups met the gold criteria of lung function impairment consistent with COPD. So important to really, take asthma seriously because it can have definitely impacts on when you're an adult. So here's my first polling question. You have considered contributing factors and confirmed a diagnosis of severe asthma for Adrian. What is the next best step? A, no change, continue to monitor. B, start oral corticosteroids. C, add a leukotriene receptor antagonist. D, try a biologic. And while we wait for the audience to take their stab at this question, Dr. Peters, are these common things that you would think about in your stepwise treatment of a patient with asthma?
Yeah, Teresa, this is exactly how we also think about when to start oral steroids, when to consider biologic. And, leukotriene receptor antagonists, we don't use it as much these days, as much as pediatricians probably use it. But in some of our patients, it is something we consider, especially, we talked about CRS with nasal polyps. There's a subset of CRS with nasal polyps who have aspirin sensitivity. That group, we use it quite a bit.
Great. And so it sounds like you guys are on the same wavelength as we are. The most common answer was D, try a biologic. So oral corticosteroids, why wasn't that an option that I would have selected? Well, these days with the advent of biologic, there's really a small proportion of children that require oral maintenance oral corticosteroids, and it's even less now in the age of biologics. And that's because the side effects with long-term use are considerable: obesity, spinal fractures, and other things. And in fact, I have had some patients that haven't responded to biologics who have required maintenance oral corticosteroids, and they have these types of side effects. So weight gain, spinal fractures, osteoporosis. They can get into problems with diabetes. And some of these patients may have corticosteroid insensitivity as well. So Dr. Peters did a really nice job of outlining the GINA 2023 update for adults. And here I'm going to focus on children. She did a nice job of covering 12 and above, so I won't cover that here. Ages 6 to 11, you'll see the choices are pretty similar. So we think about medium dose ICS and a long-acting beta agonist, or you can do that ICS and formoterol MART approach. And definitely when they get to step 4 is when they start thinking about referring to an expert, just because we know the side effects, long-term use of even medium dose ICS and LABA can impact growth. And so for a reliever, we might think about a short-acting beta agonist or use that ICS and formoterol if you're using a MART approach. We could also think about adding tiotropium or a leukotriene receptor antagonist. But if this step 4 doesn't work, we move quickly on to step 5, where we start thinking about phenotyping somebody. Are they type 2 high? Are they type 2 low? And start thinking about the biologics that are available for children in this age group, which we'll go over in subsequent slides. And kind of similar pattern on the greater than 12. You want to think about phenotyping them and thinking about the biologics that might work in that patient. And another option may be azithromycin. For both pediatrics and adults, the last resort really should be maintenance oral corticosteroids, giving all the side effects. Sometimes we have to do it, but we want to give careful thought before sort of leaving somebody there. All right. And then phenotyping. So this brings us up to what is phenotyping in asthma. So phenotypes are basically what I see in the clinic. So what kind of clinically assessed traits of asthma that might help divide patients into different groupings. And we might phenotype them based on various things. So do they have other atopic disease? Are they, have more nighttime symptoms? Are they a rapid exacerbator? How severe is their disease? What is their response to medications? And then we might sort of venture into markers of type 2 inflammation. Some people may say this gives us sight into the mechanism and might call this endotyping. And that's where endotyping is looking at different mechanisms of disease. But common type 2 inflammatory markers would be blood eosinophils, exhaled nitric oxide, and IgE. And you guys will be familiar with this slide because Dr. Peters looked at these pathways and did a really nice job of covering type 2 high, which is so common in nasal polyposis. I will focus on low type 2 on the right-hand side. That's typically triggered by irritants like smoke, pollutants, microbes, and viruses. It triggers the TSLP, IL-6, and CXCL8, which trigger the Th17 and Th1 cells, ultimately activating neutrophils. Whether you're on the type 2 high or type 2 low, it definitely leads to sort of the clinical symptoms of asthma. So hyperresponsiveness, could be remodeling in a subset, mucus production, smooth muscle constriction, and hypertrophy. And among children, just to kind of highlight some differences, about 80% have a type 2 high phenotype, and 20% have a low or non-type 2 phenotype. And it's more 50-50 in adults, right, Dr. Peters?
Actually, we think it may be more 80% type 2 and 20% non-type 2. But what's interesting is there's just so much overlap. And that overlap is seen both in asthma and nasal polyps. And potentially, at least in sinus disease, those overlap patients are the ones with more severe disease.
Right. And so have more mixed disease. So they might have features of both. Yeah. Good point. All right. Here we are at our next polling question. Together with Adrian's mother, you decide to start a biologic. You note severe atopic dermatitis or eczema in his medical history, diagnosed at 18 months of age. His mother says he still has occasional flares. Which biologic might you choose for Adrian based on FDA approval status and indications? A, dupilumab, B, bemralizumab, C, omalizumab, and D, rozanolizumab. So Dr. Peters, while we're waiting for an answer, how often do you see severe eczema as playing into your decision for a biologic in adults?
So I will tell you, Teresa, we actually do. And not just atopic dermatitis, but, these biologics, some of them are approved for multiple comorbidities, and these comorbidities may directly or indirectly impact quality of life of these patients with severe asthma. So yeah, we look at the ones that are approved for multiple conditions and potentially choose them.
All right, and we got our poll results back, and drum roll, the most common answer was A, which I agree with. Dupilumab is approved it has another indication for atopic dermatitis. So there is type 2 inflammation that is also associated with atopic dermatitis, similar to polyps. And you can see that it has similar pathways of Th2 expansion, leading to IgE production and triggering mast cells and basophils, as well as those classic atopic cytokines of IL-4, IL-5, and IL-13. So type 2 high. So there are several challenges to integrating biologics into my practice. And typically it does take several meetings with the parents and families to kind of get them warmed up to the idea of why this might be an appropriate choice for the family. So I talked to them about what biologics are approved by age, what phenotype they have, and what biologics might fit with that phenotype, what comorbidities they have, what the dosing frequency is, what kind of side effects they might have. Getting insurance for biologics can also be a challenge. They're quite expensive. Some insurances have preferred biologics, so we have to track those. They can require peer-to-peer authorization. And just to keep in mind, there are some patient programs for patients that have high deductibles. A constant concern for me is to kind of level the playing field. So I don't want the patients to suddenly drop their controllers while they're on a biologic, and often they want to do that. So I try and step them down as I can. So sometimes they'll just stop altogether and we'll lose control, and it's is it not response to biologics, or is it because they stopped their controller? So I'm always sort of cautioning people to take it step by step before we decide whether a biologic's working or not. And then there's a discussion I have about if the family's going to feel comfortable giving it in their home, or whether we should be looking at a biologic that can be given in clinic, especially in younger kids. And then there's also a resource. Do you have enough space in your child clinic to give that? So commonly observed parental concerns are, again, the side effects. A lot of them haven't heard of these medications. So they think it's something new. They think they're concerned about it. So, getting them sort of up to speed about an injectable medication for children can take several conversations. They want to know about long-term effectiveness. Sometimes the caregiver says, asthma's asthma, you're going to flare, you're going to be in the hospital, especially moms with asthma. I find sometimes just if they don't control their own disease, they don't necessarily perceive the need to control their child's disease. So sometimes it's sort of raising their hope and saying there might be something we can do here. And then, of course, time demands and scheduling conflicts can play into whether these are feasible for them. There's a financial burden and insurance coverage that are always a concern for families as well. And if we don't address these, it can impact adherence and outcomes as well. So what biologic therapies are approved for asthma in children? And here I'm going to show you some different summaries of studies that kind of give you a sense of how these biologics work. So the first one, we're going to turn to our oldest one, almizumab. We're looking at the efficacy and safety here of children with moderate to severe asthma. This is a meta-analysis, and the outcome we're looking at here is the number of exacerbations. And you can see the pooled result of these three trials favors almizumab over placebo, and the overall relative ratio was 0.51 with quite a bit of significance. So almizumab definitely decreases exacerbations. The next study, this is from the Inner City Asthma Consortium. This is studies that are done in children that live in economically disadvantaged neighborhoods. Here we're looking at the efficacy of almizumab in children ages 6 to 20 from those neighborhoods. We're looking at the percent of exacerbations on the left, and you can see in purple is the almizumab treated group, gray is placebo, and you can see over time there was a significant reduction in exacerbations in the almizumab treated group compared to placebo. On the right, however, you don't see a significant difference in the forced expiratory volume in 1 second percent predicted. And so we don't really see an impact of almizumab on lung function. So here we're looking at the efficacy of mepolizumab in children 6 to 17 years of age. This, again, was performed by the Inner City Asthma Consortium of those children from those economically disadvantaged neighborhoods. We're looking at the reduction in the annual exacerbation rate in patients that had severe eosinophilic asthma. And you can see that there was a rate reduction of 0.73% in the mepolizumab group compared to placebo, but no significant differences were seen in lung function or other secondary outcomes. Benralizumab, and looking here at the frequency of asthma exacerbations, here we're looking at the sort of approval trials in children and adults, so children were 12 and above. On the left, we're looking at the subgroup that had eosinophils at baseline of 300 or greater cells per microliter. On the right, the group that had less than 300. And you can see the annual asthma exacerbation rate. Benralizumab reduced the exacerbation rate by 45 and 51% compared to placebo in the group that had greater than or equal to 300 cells. And on the left, you can see that when benralizumab was given every 4 weeks, there was a 30% reduction, which was significant compared to placebo. But when it was spaced out to every 8, it became non-significant. So again, showing that the higher your eosinophils, the more you respond to benralizumab. The impact on the forced expiratory volume in 1 second in patients 12 and above with bemralizumab. Here you can see there was a significant difference whether you used bemralizumab every 4 weeks or every 8 weeks, depending on the study. And the ranges were 106 mils to 125 mils in the every 4-week group, and 159 and 116 mil spread in the every 8-week group. Here we're looking at a forest plot of the efficacy of dupilumab in children ages 6 to 11 years. On the left, we're looking at severe exacerbations, and we're looking at the relative risk compared to placebo by type 2 sort of baseline characteristics. So the first group is a type 2 response. That was a child that either had blood eosinophils of 150 or greater cells per microliter, or expiratory nitric oxide of 20 or greater. And you can see that the reduction in exacerbations favored dupilumab compared to placebo. And you see a similar pattern for those children that had baseline eosinophils of 300 or greater, just baseline EOs of 150, and FeNO of 20 or greater. On the right, we're looking at the change in baseline and the percent predicted FEV1. And you can see a very similar pattern, an increase in lung function by those type 2 baseline characteristics. And that response favored dupilumab over placebo. And there was actually an extension group in this age group that showed sustained improvement in lung function, a low rate of asthma exacerbations, and a consistent safety profile for up to 2 years. So here is a list of biologics approved for the treatment of pediatric asthma. And Dr. Peters went over some of this, so I will just sort of concentrate on the safety issues here. So alumizumab is approved for 6 and above. All the biologics can have injection site reactions. And so that's something that you can see with any biologic. It's typically hives or swelling around the injection site. But there's some agent-specific adverse reactions. So serum sickness or hypereosinophilic conditions can be seen. And there is an anaphylaxis black box warning. So patients always need to carry an EpiPen because there's been cases of delayed hypersensitivity reported. It's typically in adults. We don't see it as much in kids, but it is something to look for. Mepolizumab, again, approved 6 and above. Agent-specific adverse events is parasitic infections or hypereosinophilic conditions. Rare adverse events would be hypersensitivity reactions or herpes zoster infection. Dupilumab is approved 6 months and above for eczema, but 6 years and above for asthma. And common adverse reactions, we saw colds and nasopharyngitis. Agent-specific, there is a risk for transient eosinophilia that happens, it peaks about week 12 of treatment. Parasitic infections can be a concern, and conjunctivitis, particularly in children that have atopic dermatitis. You also can rarely see hypersensitivity reactions. Bemralizumab is approved in 12 and above. It too was common nasopharyngitis was seen. Parasitic infections remain a concern, and a rare side effect would be hypersensitivity reactions. Tezepelumab is approved in 12 and above. Nasopharyngitis, viral upper respiratory infection, headache were all common adverse reactions. And agent-specific pharyngitis, arthralgia, back pain, and hypersensitivity reactions were seen. Most of these pediatric safety data are from trials less, a year or less in duration. And I would say my overall comment is very long-term safety trials is an area of understudy. So what are some of the eligibility criteria, but also response? So what kind of predictors predict response to biologics? And this is, I'm going to focus on children, but I think these are very similar in adults. So alumizumab, its target is IgE. Eligibility criteria, you need to have either one positive ear allergen skin prick test or a specific IgE. And there's this very complicated dosing chart that looks at, height of IgE and weight and you see if they fall within that dosing range. And then they need to have at least one exacerbation in the past year. Predictors of good asthma response: higher eosinophils, higher exhaled nitric oxide, so getting that theme of type 2 high, allergy-driven symptoms, and childhood onset asthma are all predictors of good response. Pembrolizumab, mepolizumab, they target anti-IL-5 and anti-IL-5 receptor antagonists. They look for exacerbations in the past year and blood eosinophils of at least 150 or greater. Predictors of response, again, are that higher type 2, so higher blood eosinophils, more exacerbations in the past year, having an adult onset versus child onset of asthma, and nasal polyposis. Dupilumab, its target is an anti-IL-4 receptor. Eligibility would be an exacerbation in the past year. Blood eosinophils between 150 and 1,500. The reason for that is if you get above 1,500, there's a worry that the possible increase that we transiently see with dupilumab may put them into a range that isn't safe. So we really need to monitor people closely. And then exhaled nitric oxide of 25 parts per billion or greater. Also, if you're taking maintenance oral corticosteroids, that's listed in the FDA label as an indication. Again, the higher the type 2 response, the more robust the response. Tezepelumab is an anti-TSLP target. It's you don't need to phenotype patients to put them on this, but they do need to have an exacerbation in the past year. So our next polling question: how confident are you in your ability to assess the effectiveness of Adrian's biologic treatment on asthma? A, extremely confident; B, very confident; C, somewhat confident; D, not very confident; E, not confident at all. So Dr. Peters, do you feel like adult primary care providers, are they aware of biologic therapy? Do you feel like that's an increasing awareness, or?
I think it depends on where you the primary cares are from. I do feel in Chicago they are quite aware, and I see the poll results are in interest of time. I'll let you get to it.
Sure. So they're somewhat confident, and I would say some pediatricians are aware of this, but I think it's still, we're bringing up awareness of these things. So typically, I take about 4 to 6 months to decide if biologics working, possibly up to 12 months if I feel like there's been partial response. We look at sort of all the typical measures of asthma control. So I'm going to look for exacerbation reduction, symptom improvement, less albuterol use, reduction in oral corticosteroid or systemic corticosteroid use, quality of life improvement, decrease in healthcare, and lung function improvement. So Adrian is doing pretty well. He started on dupilumab, and 12 months post biologic initiation, mom's reporting no exacerbations, only occasionally using his rescue inhaler. He's had no eczema flare-ups. He told me he was actually able to play football for the first time. And his blood eosinophils are now less than 150 because he's been on dupilumab for a while, and his exhaled nitric oxide is in a normal limit. So in summary, severe asthma represents about 5% of children with asthma. 80% of children with asthma have type 2 predominant phenotype. When managing moderate to severe asthma in children, we want to assess their comorbidities and confirm the diagnosis, assess barriers to care and adherence, and take a stepwise therapeutic approach with that focus on phenotyping. There are new therapies that are emerging, and of course, I'm always going to be an advocate for child-specific research, especially long-term efficacy and safety.
Thank you so much, Teresa. You know, we are past our time, but maybe we could take one question if someone has any burning questions, or you can always get hold of us later as well. And, you know, one we could consider is just, if no one has a question, I could ask Teresa this, which is, which biologic, and you just went over a lot of this, so oh, it'd be easy for you. Which biologic has the fewest side effects in children? Is that something you could answer? Or
yeah, I mean, I think overall the biologics tend to be pretty well tolerated. As I said, almozumab does have the black box warning. They have to carry epinephrine, but I rarely see. Actually, in my practice, and I have like over 200 kids on biologics, I have not seen, knock on wood, anaphylaxis reaction. So I think it's pretty rare. We still have to take it seriously. But most of them, what I see is a little bit of site reaction. That's mostly what I see. I haven't really had to discontinue anyone from that. I had one patient that had some hives, and so we talked about whether we wanted to discontinue or not.
Yeah, I feel in the adults we see it too. They do pretty well on biologics. Most are well tolerated. In an interest time, we'll move on to the next slide. And I really want to thank you guys all. Thank you, Stacy. Thank you, Teresa. And thanks to our audience. I would like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. We all care a lot about asthma. And please remember to complete the post-test at the end of the session to secure your CME credits. And please visit immunologylive.com and resinsightslive.com to view today's session, along with other sessions on demand. I am Anju Peters, and thank you so much for joining us.